Choosing cancer therapy is complicated. We obviously want to choose not only the therapy that's going to be the most likely to cure a patient, but we don't want to lose the patient while going for the cure. And so indeed, there are sometimes we have curative therapies, but we have therapies that might cause a patient's death in a short term, and therefore we withhold that therapy until it looks like the disease is going to cause more problems. So it's survival without disease sometimes versus survival with disease. And in fact, sometimes survival with disease has a better chance of keeping a patient alive than survival without disease. And there becomes a break point in most patients' disease in which we say they're not going to survive very long with disease anymore, so it's time to increase their chances of therapy. Uh-oh, what did I do? It's time to increase their chances of cure by bringing in therapy that might have a little bit more in the way of side effects. So there are a variety of factors that we consider when choosing which therapy to give a patient, conventional or high-dose therapy, and that is curability at the various stages of disease. We don't want to take a patient with a curable disease earlier in their course of therapy, wait until it's too late, and then try to bring the cure in because it may not be successful. So that's an important issue. And there are types of transplants in which we can use as a last resort, but in general, most of the time not. We have to determine whether a patient can have an autologous versus a donor transplant. Autologous transplants are usually associated with a better chance of making it through without dying of a complication. We need to determine what the goals of transplant are going to be, a long-term remission or a cure, the anticipated complications and quality of life impact that patients undergo, and patient factor like compliance. Now that we have donors for everybody, we need to figure out, is this in the patient's best interest? Are they going to follow through with therapy? And indeed, somebody who needs a liver transplant or heart transplant, compliance to that type of therapy is a critical factor. If there are 100 patients that need lung transplants, and you have 50 lungs to give patients, believe it or not, some of the decisions that are made of which 50 get that might in fact have to do with, is this patient going to be reliable and take their immunosuppressive therapy, or are they going to waste the lungs that I'm going to give them and therefore I should give them to somebody else? That's not the case here, but we do need to consider those issues in determining. We don't want to shorten somebody's survival, and we need to take that into consideration, and that's why all of our patients undergo psychological evaluations. So what I'm going to do is give you two examples of how we make these decisions, and as you go through the morning, you'll get a little bit more disease-specific information. And so we're going to talk about allografts and its decision-making process in acute myeloid leukemia and autologous transplants in large cell lymphoma. So let's talk about hematologic malignancies in general, including acute leukemia. A complete remission is a normal blood count. For leukemia, a bone marrow that shows less than 5% blast. But a remission in leukemia does not equate with a cure. In fact, for patients above age of 60, remission equates with a cure in only about 5% of patients. In younger patients, a remission equates with a cure in about a third of the patients. So a cure, on the other hand, is usually designated as a remission lasting for more than 5 continuous years after therapy ends. So you'll find that most hematologists and oncologists don't like to use the C word, the cure word. We talk mostly about remissions and survival. And obviously, from a patient perspective and from a doctor perspective, survival is obviously the gold ring. And obviously, survival without disease means cure, and that's what we all shoot for. So indeed, there are different phases. Again, the mustard stain on the shirt analogy, when we see a patient with acute leukemia or lymphoma, we give them initially induction therapy, which is designed to reduce the malignant cell numbers to undetectable amounts. And then we give them additional therapy, which we call consolidation, which is designed to reduce the malignant cell numbers to 0 or to a point when the body's immune system can handle what's left over. And maintenance therapy, which is given to try to prevent the regrowth of very low levels of disease. It's very rarely used in adults anymore. It's used typically in children with one disease, that's acute lymphoid leukemia. So with the baby boomers aging rapidly and the peak incidence of AML being 68, it's expected that there's going to be a doubling of the number of cases of AML in the next 10 years. So we're more focused not on the 20 and 30-year-olds with AML, but on the 60-plus-year-old patients. This is a significant problem. And indeed, we divide patients by age because it's one of the most important prognostic So all hematologic malignancies have major factors that influence prognosis and thus how we approach a patient in treatment decisions. And that's why, again, the panel is so important at the end of this meeting, because everybody is different. Every situation is different. Every clinical scenario is different. The things that you bring to the table, the things that your disease brings to the table, the things that we bring to the table are all different. So for leukemia's age, above age 60 is bad, so I'm in the bad group. Chromosomal molecular abnormalities, there's the good, the bad, and the intermediate. And then if you had another cancer or a prior blood disorder and then developed leukemia, that's also bad. But these are the big three, and of the three, age is the most important. So most important, usually defined as age above 60. Older patients present with more resistant disease, and thus their prognosis is lower than younger patients. But also older patients bring to us more complications. They have bad hearts, bad lungs, if they're smokers, if they have diabetes, if they have high blood pressure, all that enters into the prognosis. And for older patients, the 5-year survival with standard therapy is less than 20% versus 30 to 40% for younger patients. So that's something that we take into consideration. So a younger patient who comes to us with leukemia, we say, you might not need transplant, but an older patient in general, because this is a survival curve, and this is months after register, this is months after diagnosis, so to speak. So at 2 years here, 24 months, you can see the average patient with leukemia above the age of 55 even has a 20% chance of being alive, versus somebody who's less than 56 years old who has a 50% chance of being alive. And these patients out here, these ticks, are actual alive patients. These are patients that are in general probably cured of their disease, which happens very rarely in older patients. So these things we do consider in making treatment decisions. Obviously, if you wait till somebody's beyond a year or more, then the chances of pulling them out of the fire, so to speak, become less, because they're in a situation where they're likely to die in a short period of time. So there are chromosomal abnormalities